going to talk to us. I think clearly an interest in immuno-oncology is important, and the interaction between that and radiotherapy is really a novel area for both clinical care and research. So Roy, thank you.
Thank you, John. I want to thank Kerry as he runs out early today for making me immediately uncomfortable that I have disclosures on my title slide. But I'm actually not going to be talking about any of those things. So I want to talk today about combining radiation and immune checkpoint inhibition in non-small cell lung cancer, specifically in the metastatic setting. And my goal is to convince you that radiation activates innate and adaptive immunity, that this is an important mechanism. We know this is an important mechanism for the radiation response locally. And some great work done at the University of Chicago shows that, for example, if you block the STING pathway, you can really blunt the immediate local response to radiation, kind of suggesting that that is responsible for some of the direct effects that we see in tumors. And we think we can exploit this to enhance the systemic anti-tumor effect. So I'm going to give a little bit of background, and then we're going to talk about a clinical trial that kind of sucked up every moment of my life for several years here at the Cancer Center. So we've known for many years that radiation can induce systemic immune responses. And when I was a resident, we had to learn this word, abscopal response, which no one else had ever heard of. And it was based on these case reports of patients who were not on any systemic treatment that got radiation to a single site of disease and had some partial or complete response in other areas. And the assumption was that this was likely radiation setting off an anti-tumor immunity. This is a collection of case reports that kind of summarizes the published data on this. And I think the most important thing is they only found 46 case reports over about 45 years, which shows you that this was not a very common effect. And with radiation alone, it was probably not something that was worth trying to exploit in the general population. So you may have heard that immune therapy is now being used in cancer patients. So obviously there's been a lot of excitement, and this has kind of taken over a lot of clinical cancer research over the last decade. A renewed interest in the abscopal response was engendered by some case reports. And this is one in a lung cancer patient treated down at NYU. The patient had had multiple lines of chemotherapy, was put on a trial where they received palliative radiation to a liver metastasis, and then received 3 cycles of ipilimumab starting during radiation therapy. So ipilimumab alone should not really have any significant systemic effect in a patient with metastatic non-small cell lung cancer. In this patient, not only did they see resolution of the liver metastasis, which is in the top panel before and after, but also a complete or near complete response in multiple other metastatic sites. And this was accompanied by a spike and then a decrease in CEA that lasted for at least a year. Tumor biopsies show that a dense lymphocytic infiltrate accompanied the radiation, not only in the radiated tumors, but in the other tumors. Again, confirming that this does seem to be an immunologically mediated effect. Dr. Fermenti, who was the doctor for the study, did a proof of principle trial, which I thought was very interesting. This was a trial in solid tumors, 41 patients with at least 3 sites of disease. And what they did was they gave radiation to 2 of them sequentially. And then they looked to see response in the 3rd site. And they used GM-CSF, a growth factor, to help stimulate the effect of the radiation on the immune system. And what they found was about 25% had some kind of response, partial or almost entirely partial responses in the non-radiated lesion. So again, providing evidence that this is something that can be exploited in humans. So we've also seen from subset analysis of some of the KEYNOTE trials. This is the KEYNOTE-001. This is a post hoc analysis where they broke down the responders by whether they had a history of prior radiation. And what they found was that the people who had had radiation for palliative reasons before starting the PEMBRO had a longer PFS, a better survival, and maybe a slight uptick in toxicity, but nothing significant. So again, not a pre-planned analysis, but a suggestion that the presence of radiation prior to starting that immune therapy may have enhanced the response. So so what I want to talk about today is a trial that we conceived of and started actually many years ago at this point. PEMBRO is actually not approved for any cancer site when we actually started enrolling on the trial. I think it was approved for melanoma about 2 weeks after we opened, which was quite inconvenient. And so we didn't know a lot about the safety of radiation with immune therapy. Clinical trial data from PD-1 inhibitors alone showed that there was a suggestion of pneumonitis, and that was a concern that we would set off some unreasonable amount of toxicity. So we embarked on this trial. It's a seamless phase 1, phase 2 trial. There was a dose escalation phase where we started with very conservative doses of radiation. The trial was initially open to both melanoma and non-small cell, but what we're going to talk about today is the non-small cell cohort. This is really the expansion cohort, and our primary objective here was to determine the overall response rate when we added radiation to pembrolizumab and patients were progressing, and I'm going to kind of show you what it looks like. So this was the initial trial schema. So what we were going to do is we were going to take patients who were naive to immune therapy, and we were going to start them on pembrolizumab, and we were going to wait for them to progress. And actually, the way we wrote the trial, we had to confirm progression with a second scan. So we were really making sure that they met the immune resist criteria. They had to have multiple sites of disease. We were going to radiate one of them, and then we were going to re-challenge them with PEMBRO and see if we could induce a response in patients who were already progressing. So this trial was initially open to melanoma and non-small cell. So as I said, about 2 weeks after we opened it, PEMBRO was approved for melanoma. And of course, it wasn't really reasonable to accrue to this trial. So we kind of had to revise the criteria about 6 to 9 months after it was approved. PEMBRO was approved in the first line, or actually in subsequent lines for non-small cell. So this was the revised design. We actually decided to enroll patients who had been treated with either pembrolizumab or nivolumab off trial. They had to have demonstrated again serial progression of disease. At that point, they were enrolled and treated with SBRT immediately. So the real thing to keep in mind as we talk about some of these data is we are measuring a response in the lesions that we did not radiate. And again, this is in patients who are already progressing when we enrolled them. So this is our consort diagram, and it's a little busy because, of course, we had 2 different enrollment strategies here. We enrolled 50 patients who were immune therapy naive and treated them with PEMBRO. Of course, a lot of them responded, never got to the radiation. So 16 of those progressed and were treated. When we revised the trial design, we enrolled 6 more patients who had progressed on prior standard of care immune therapy. So we wound up treating 21 patients with SBRT and then measuring their response. So the numbers I want to keep you in mind here is when we talk about responses to pembrolizumab alone, we're talking about 50 patients, and when we're talking about responses to SBRT followed by pembrolizumab in patients who are progressing, we're talking about those 21 patients. So these are the patients we enrolled. So a grand total of 56 total. Most of them had prior therapy. We enrolled regardless of PD-L1 status, and this was checked afterwards. So using a cutoff of greater than 0%, more than half of them were PD-L1 positive. A few of them we were really not able to ascertain, but only a third were PD-L1 negative. And again, these are generally archival tumor samples that were taken, very often not fresh. So these are the toxicities. So again, when we designed the study, we were concerned about the toxicity of combination therapy. In the green boxes, you see any grade toxicity and high grade toxicity in the 50 patients who received PEMBRO alone. And this is very much in line with what's in the literature with PEMBRO alone. In the, we decided that was about a salmon colored columns on the right. That's any grade and high grade toxicity in patients who received the PEMBRO after SBRT. So first, there was no dose limiting toxicity here. There was no prohibitive toxicity. Overall, the combination was safe and well tolerated. And this has been used as preliminary data to justify some prospective trials that we've been doing in the cooperative groups. We do see perhaps a slight uptick in low-grade toxicities after radiation, which I think is interesting, that we, in fact, may be engendering some kind of low-grade autoimmune response. So this is the efficacy results. So the disease control rate, which again, for those of you who don't do this all the time, is stable disease plus partial responders plus complete responders, was 57%, which is to say that in a population of 21 patients who had been progressing radiographically, more than half of them had at least stable disease afterwards. We had, so that was most of them. We had 2 people who had prolonged partial responses for more than a year. And we had 6 patients who pretty much progressed either radiographically or clinically very quickly after SBRT. Let's see. So there's a lot of data on here in the table on the right side. And actually, I'm going to go over a lot of these things. So I'll just skip over that for the moment. So this is our waterfall plot. So again, these are the patients who have previously been progressing. We did have a significant number of partial responders with a pretty prolonged duration of response. Those who had the best radiographic response tended to be the ones who had the longest response as well. We had a number of patients who were really not able to measure their radiographic progression because they simply could not tolerate continuing therapy, usually due to clinical progression of disease. So we counted these as failures. Those are those gray bars. And again, the SBRT target lesion is not counted here. So the addition of SBRT resulted in a mean of 150 days before further disease progression. So that is to say the patients who responded had almost 6 months of further therapy with PEMBRO. This was significantly longer in the patients who had a PD-L1 score of greater than 0. So more than 190 days for PD-L1 positive patients versus 93 days in PD-L1 negative patients. We looked at tumor infiltrating lymphocytes, and again, people with high TIL scores, 2 to 3, had an average of 215 days of response versus 60 days in patients who had a low TIL score, and that makes a lot of sense. If you think that radiation is, inducing, the production of additional antigen, you would certainly want to have an pre-existing tumor infiltrating population to take advantage of that. We also found that patients who had developed any immune-mediated adverse event had a significantly longer response time, 208 days versus 90 days. There's a little bit of selection bias in this. Obviously, if you're on therapy for a longer period of time, you're more likely to be counted as having an immune-mediated adverse event. But this also makes a logical sense that people who are having an active immune response to the combination therapy are also the ones who are most likely to develop an active autoimmune response. So now I'm going to talk a little bit about translational studies. So a lot of this data is very, very preliminary. And I'm going to thank all the people who worked very hard on this. One of the great things about working at Yale is all the amazing collaborators that are available. A lot of this work was done by tissue samples that were collected with the help of Kurt Schalper here, but also processed with the assistance of Bobby Patel and Sue Keck, who continues to work with us out in California. And some of the data analysis you're going to see in the next few pages was done by the laboratory of Smita Krishnaswamy, who really did an amazing job, not only in analyzing our data for it, but explaining it to me in small words that I could understand. So what we did first was, so this is CyTOF. We did CyTOF on peripheral blood at multiple time points before and after the patients received SBRT while they're receiving immune therapy. We used a system called FATE, which I'm going to explain in a second, to visualize it and cluster it. And we identified 6 clusters of cells on a lymphocyte panel. So the typical CD4 positive helper cells, myeloid cells. We identified a population of exhausted T cells and cytotoxic cells. And we also identified an interesting population that we're not really quite sure what to make of. We'll talk about it a little bit more, but there's this CD3 negative FOXP3 positive cell population that's a little bit difficult to characterize because, again, this is a lymphoid panel, that actually seems to be the most interesting in terms of correlating with response. We'll talk about it a little bit more here. So this is Dr. Krishnaswamy's work. And if you're a dinosaur like me, when you used to do FACS analysis, sometimes we would get as fancy as to look at two markers at the same time, and we could graph them on the X and Y axis. So the question is, how do you visualize data when you're checking for 33 cell surface markers simultaneously and analyze it? And so this is FATE. The important thing in looking at this, if you look at the upper right-hand panel, is this is really just a simple way of representing essentially 33-dimensional data that we can use for identifying populations that share groups of cell surface markers. In looking at this, the first thing I had to get over was the fact that the X and Y axes are fairly arbitrary. We're really looking for the heat maps. So in the upper right-hand panel, you can see visually represented these 6 clusters of cell populations that we identified. And as an example, our T helper cells in the lower right-hand corner of that upper right-hand panel, and that little green bar sticking out is this mystery population of CD3 negative cells, which are FOX3 positive. So once you've kind of visualized these 33 different cell surface markers simultaneously, you have to ask how you're going to compare them using categorical variables like like before and after treatment, for example, or good responders versus poor responders. And MELD is a system that, again, Dr. Krishnaswamy and her postdoc have worked out to help denoise the data, filter it, and essentially create maps of cell populations that are representational of different categorical states. This will be a little clearer in a second. So if we look at, for example, response as a categorical variable, we're looking at poor responders to SBRT plus immunotherapy versus good responders of SBRT and immunotherapy. What we can see in the upper right-hand panel is that little purple area that's sticking out to the left is that population of CD3 negative, CD158 positive, FOXP3 positive were much more abundant in patients who were poor responders to this combination therapy. We can also look at time as a categorical variable, but that's on the bottom. We do see some differences before and after radiation that we're still characterizing. But there are some changes in the T cell populations, as you would expect after you deliver SBRT in the peripheral blood. So MELD allows for visualization of these markers, not only the clusters of cells among categorical variables, but we can look at specific cell surface markers before and after treatment. So the bottom row, what you can see is after radiation, you do see a decrease in inhibitory markers such as CD25, FOXP3, an increase in markers that are associated with inflammation such as Ki67, TNF, and CD36. So we think what this demonstrates is that, again, consistent with our clinical data, we are engendering an immune response. These data are not filtered by responders on this bottom panel. So what we're seeing here is we are engendering an immune response with the radiation, even in patients who've been on immune therapy for a prolonged period of time. But we have not yet identified what determines whether a patient's going to then turn around and start responding or whether they're going to continue to progress. So if we do look at, for example, excellent responders versus poor responders to a combination of, again, SBRT and PEMBRO, we see an increase in effector CD8 cells, decrease in IL-10, and we see some changes in the myeloid compartment, all of which kind of makes sense. We're seeing an active, immunity reflected in the peripheral blood of the patients who are clinically responding, clinically and radiographically responding. So this is where I admit that all the data that I showed you is based on 6 patients. And what we did was we took 2 patients who were poor responders, 2 patients who were great responders, and 2 patients who were kind of meh. We analyzed differences among those. The bottom bar graph in the middle is the representation of those 6 patients. The bottom right bar graph is data that I saw for the first time yesterday. And that represents a new run of several additional patients, which really just show very consistent results. So this very preliminary data does seem to be at least holding up as we continue to analyze these. So this again is a fairly preliminary. So if we look at patients who respond versus don't respond to this strategy, the biggest change we've seen is in this population of CD3 negative cells, which has really made me regret deciding on a lymphoid panel, by the way, rather than a myeloid panel when we first ran these cytoph samples. We are seeing some subtle changes in the exhausted T cell group and maybe the cytotoxic T cell group. We're not really sure whether any of those very small differences are ever going to hold up. And so this has engendered a lot of interest. So the nice thing, one of the lessons we learned is that if you gather clinical samples and start showing them around to brilliant scientists, they come up with a lot of great ideas to look at them. So working with one of Sue Keck's collaborators at UCSD, Mohit Jain, we're starting to do metabolomics on these. We're looking at a total of 267 molecules in these super classes. So far, we're starting to run these on all of our samples, so regardless of whether the patients received SBRT or not. So we have, again, as a reminder, a huge number of patients who really just received PEMBRO. So these are all just unique metabolites. We are really just looking at the differences here. So very preliminary studies so far. So just to kind of summarize what we talked about clinically, so I think what we've done in this small trial is show that the addition of radiation to immune therapy did result in a significant response of almost 6 months in patients who were previously progressing. We've actually identified, again in a very small study, that patients who are PD-L1 positive, patients with a high TIL score, may be the ones that benefit from this approach most. I'm really very hopeful that some of our correlative data may show some immunologic biomarkers that suggest which patients would benefit from the additional immune stimulation of radiation. We're really just very preliminary on our immunologic correlates at this point. So we are continuing to analyze our cytoph. We have more panels to run. We have more samples to run. Sue Keck has already started running single-cell RNA sequencing on this mystery population of CD3 negative cells that we've identified. We really do think there's something real going on there. And we have other correlative studies that we're hoping to look at. And Avi Patel has a lot of our samples, some of which have been analyzed and some not. And we're starting to look at metabolomics. So again, we think this trial has already provided data to justify some upcoming and ongoing trials simply based on the initial safety reports. And I think this will help narrow down clinical focus on what population may be best suited for this kind of strategy. So acknowledgements. So first of all, a huge shout out to Allison Campbell in our department who really pulled all the translational data together and has really done an amazing amount of work. And our translational collaborators here for really getting excited about all the opportunities that were here. We first talked about this trial with Scott Gettinger and Harriet Kluger, but all of our collaborators in the lung group. Kurt Schalper, I think I met with him on his first week here to talk about sample collection. And I'm not sure either one of us knew how to find his office at that point. A huge amount of work by our TRAD DART team, and thanks to the Cancer Center providing us for the resources to do exciting trials like this. So happy to take any questions. This is the best team for Closer to Free Ride, is the Hunter accelerators from Therapeutic Radiology.